Hello everybody, my name's Mhairi Copland. I'm Professor of Haematology at the University of Glasgow, and today I'm going to talk to you about the biological nature of CML stem cells and the role of the immune system in treatment for remission. These are my disclosures. So first of all, to think about some of the scientific milestones that are relevant to the CML stem cell. And the Philadelphia chromosome was first identified in the early 1960s. And then it wasn't until the late 1970s that evidence for the clonal origin of leukemic stem cells was identified. The fusion between BCR and ABL was identified in the early 1980s. And then moving on from there, in the early 1990s, the first evidence of leukemic stem cells in long-term co-culture was seen for CML. Tessa Holyoake was the first to identify the quiescent Philadelphia chromosome positive CML stem cell in patients in 1999. And following on from this, her lab and others identified that leukemic stem cells were insensitive to TKIs in vitro and in patients. Then in 2011, both Tessa and Michael Deininger's labs showed that leukemic stem cells are capable of surviving independent of BCR-ABL. And more recently, the labs of David Vitry and Vigner Helgeson have shown that the CML stem cells have an altered genetic landscape, and they also have an altered metabolism with dependence on oxidative phosphorylation. So there's an emerging viewpoint that to develop therapeutic strategies for CML, we need to target the minority of the cancer stem cell population in order to completely eradicate the tumour. So most conventional cancer therapies, including TKIs, target the rapidly dividing progenitor cells, but don't hit the stem cells. And this results in tumour relapse. And what we want to do is identify targets on the CML stem cells that we can hit to eradicate the stem cells that will then over time result in tumor regression. So what are the features of a CML stem cell? Well, these cells are quiescent and they're capable of self-renewal. They're primitive and capable of long-term culture-initiating cell growth in engrafted mice. They express BCR-ABL1, but they're capable of surviving full BCR-ABL kinase inhibition with TKIs. Most leukemic stem cells do not have kinase domain mutations unless it's patients with advanced disease. Leukemic stem cells are not oncogene addicted. They do have high levels of reactive oxygen species and genomic instability, and this can lead to acquired TKI resistance. So this is a figure just thinking about how the leukemic stem cell changes over time. And at the bottom, we've got normal hematopoiesis, and it starts with the hemangioblast moving to a hematopoietic stem cell, then through to progenitor cells and differentiated cells. And self-renewal is very high in the hemangioblast and hematopoietic. Very little self-renewal in differentiated cells. The CML stem cell arises most likely from a hematopoietic stem cell. And for most patients with chronic phase CML, the BCR-ABL mutation is the only mutation that they have. And treatment with tyrosine kinase inhibitors will eliminate most of the CML stem and progenitor cells, but you may see leukemic stem cell persistence in many patients. This is associated with quiescent leukemic stem cells, and this causes residual disease when TKIs are removed. In some patients, we do see progression, unfortunately, and TKI resistance, either with a BCR-ABL kinase domain mutation, such as the T315I mutation, or some patients may progress to blast phase with the acquisition of additional cytogenetic abnormalities, which leads to an acute leukemia. And these patients are also at a higher risk of developing BCR-ABL kinase domain mutations. In addition, as the disease becomes more resistant or progresses, there's an increase in reactive oxygen species and an increase in DNA damage, further leading to the acquisition of additional abnormalities and a more aggressive disease. Thinking about the epigenetic and metabolic landscape within CML stem cells, there are a number of different abnormalities. And we know that there's abnormalities of fatty acid metabolism, the tricarboxylic acid cycle is abnormal, as is amino acid metabolism. And there have been a number of studies done over the years looking at these different areas and potentially trying to target these within the CML stem cell. Thinking about the epigenetic axis, there are abnormalities within EZH2 and SIRT1. And again, there's an EZH2 inhibitor, which could potentially be CML, and also DNA methylation inhibitors can be used to target the SIRTs. So within the Glasgow CML lab over the last 25 years or so, our hypothesis has been that CML stem cells utilize multiple cell intrinsic pathways together with microenvironmental and immune cell interactions to evade current therapies. And our lab and many other labs across the world have identified many clinically relevant targets on CML stem cells, including P53, c-Myc, EZH2, CD93, CD26, and PPAR gamma. And the hope is that these would lead to improved therapies for patients with all phases of CML within the future. So why do we need to target CML stem cells? So for those patients that have CML persistence, they are drug dependent and they have a chronic disease. They require ongoing medical attention and they remain at risk of developing mutations or resistance. And we shouldn't forget that tyrosine kinase inhibitors are likely to cause side effects in patients, which can lead to compliance issues. For many of the tyrosine kinase inhibitors, there's quite significant cost implications. And there's also the psychological and social issues of having a cancer diagnosis and being on long-term anti-cancer therapy. If we're able to eradicate the stem cells, then we would hope to be able to cure patients with a finite treatment program, potentially reduce the costs of treatment in the long term, and there would be improved psychological and social well-being for patients. In the second part of my talk, I'm going to move on to speak about the immune landscape in CML and the effect of tyrosine kinase inhibitors. And there's no doubt that CML at diagnosis is characterized by immune dysfunction, and this prevents host development of anti-leukemic immune responses and facilitates progression and self-preservation of the tumour. And there's dysfunction of both the innate and adaptive immune responses. And in terms of the innate immune response, we see abnormalities of dendritic cells, plasmacytoid dendritic cells, NK cells with reductions in NK cell counts and cytotoxicity, and also antigen-presenting cell function. In terms of the adaptive immune response, there's effects on the CD8 positive cytotoxic T lymphocytes with high levels of PD1 and PDL1, suggesting T cell exhaustion. And we also see high levels of leukemia-associated antigens. There's also high levels of myeloid-derived suppressor cells and T regulatory cells, which can also contribute to T cell dysfunction. And this is all highlighted in the figure on the left. And when TKIs are given, we see that these do inhibit many of these adverse effects on the immune system, returning the immune system to a more normal setting. But the TKIs themselves can also have some effects on the immune system. Looking at some specific examples within the immune system in TFR, there's a possible role for NK cells in successful treatment-free remission. So within CML, in successful TFR, there's an increased proportion of cytotoxic CD56 DIM and memory-like CD57 NK cells. These are associated with the production of interferon gamma and lead to elimination of leukemic cells. And in terms of activating receptors on these cells, they have increased levels of activating receptors for those patients in MMR and MR 4.5, and this can lead to prolonged deep molecular remission. Thinking about the inhibitory receptors on the NK cells, these can lead to decreased NK cell toxicity and lower molecular remission. And these are the KIR ligands. So For those patients that have a failed molecular remission, we can see alterations in these, and they're also altered by TKI treatment. So, for example, patients with a KIR genotype with KIR 2DL2, DL5B achieved lower molecular remission rates on TKIs. There's also been a role of plasmacytoid dendritic cells identified in deep molecular remission in CML. And recently, the EUROSKI and CML5 TIGER studies have shown that high numbers of CD86 positive plasmacytoid dendritic cells in patients with molecular recurrence after a TFR attempt. So if we just look on the figure on the right, this is in the first figure in A, this is comparing normal donors with patients going into EUROSKI who are in molecular remission. And you can see that the number of CD86 positive plasmacytoid dendritic cells is higher in those patients in molecular remission in EUROSKI as compared to normal donors. However, if you then look at patients later on in EUROSKI and you look at relapse versus no relapse, you can see again significantly higher levels of CD86 positive plasmacytoid dendritic cells in those patients that have gone on to have molecular recurrence. And this was associated with T cell exhaustion, increased levels of PD-1 on the CD8 positive cytotoxic T lymphocytes. So it's hypothesized that low levels of CD86 positive plasmacytoid dendritic cells may be predictive of treatment-free remission. And this is just shown in chart C in the relapse-free survival, where in the red line we've got those patients with lower levels of the CD86 positive cells having superior relapse-free remission as compared to those with higher levels of CD86 positive cells in green, which had a very high level of molecular recurrence. It's also important to note that high numbers of BCR-ABL positive plasmacytoid dendritic cells are associated with inferior rates of deep molecular remission after nilotinib, and these cells express high levels of inflammatory cytokines and chemokines, and it's likely that these stimulate leukemic stem cell persistence and immunosuppression. So how can we use the immune response to enhance treatment-free remission? And there's a number of different approaches. If we first of all think about non-specific approaches, probably the one that's most widely known to people is the use of interferon alpha, and I will talk a little bit more about that. But we should also turn to our transplant colleagues and think about what they have done to cure CML in patients, and not just with stem cell transplant, but we also have the immune manipulations of donor lymphocyte infusions, immunomodulator mesenchymal stromal cells, and also CAR T cells, which have been used in patients with Ph positive acute lymphoblastic leukemia. In terms of more precision approaches, vaccines can be developed to leukemia-associated antigens such as WT1 and PR1 peptide, but to date these have had a very limited success. You could also look at immune checkpoint inhibitors to try and reverse T cell exhaustion, and we could also adopt non-immune approaches, as I've discussed in the first part of the talk, to specifically target pathways within the CML stem cells. So one big question is, does interferon alpha have a role in treatment-free remission? Interferon alpha induces non-specific immune responses, so it's an activator of T cells, NK cells, and dendritic cells, but it also targets proliferating CML stem cells and causes them to undergo apoptosis. Interferon alpha is thought to work more effectively in the absence of a high tumour burden, so TFR sounds like a really good place to try and use interferon. And studies have shown that TKIs plus interferon alpha lead to faster induction of deep molecular response in more patients than TKI alone. And if we look at the bar chart here, and this is not a randomized study, this is a side-to-side comparison of patients in the NORD-CML7 study, which combined TKI with interferon as compared to decision data where patients were on dasatinib alone. And if we look at both the MR4 and MR4.5 rates at each time point, we can see superior levels of response for the combination of dasatinib and interferon. So based on this has now been taken further into prospective randomized studies to assess the role of pegylated interferon alpha in the maintenance of TFR after a TKI stop. And the largest study to do this is the CML5 Tiger study, and I'm delighted that my colleagues over the next few slides have been generous enough to provide me with slides and updates of their studies. So the CML Tiger study is randomizing patients between a nilotinib alone versus nilotinib plus pegylated interferon at induction. And this is followed by either continuing nilotinib maintenance or continuing interferon alpha only maintenance for a period of at least 12 months, followed by treatment discontinuation and assessment of treatment-free remission. And this study is now in follow-up, and we would hope to see the results very soon. The second study is the Endure study, and this is looking at interferon alpha to maintain TFR after a first or a subsequent TKI stop. So in this study, the interferon is given following the TKI. There's a 1 month period where patients get both, but thereafter they stop, and then there's a 1-to-1 randomization between patients receiving interferon alpha or being surveyed for 12 months. And the success rate for treatment-free remission is followed out to 5 years on this study. The other area of treatment that we could think about is immune checkpoint inhibition to improve T-cell exhaustion. And PD-1 is expressed on CD4 positive and CD8 positive T-cells in TKI-treated remission CML patients. This suggests T-cell exhaustion may still occur even in deep molecular remission and may contribute to TFR failure, and so provides a rationale for the treatment with checkpoint blocking antibodies to PD-1, PD-L1, or to CTLA-4. And this is being assessed in the ongoing French ActiW study with the PD-L1 inhibitor avelumab. And this is just an outline of the avelumab arm of the ActiW study. And this started to recruit in July 2019 and to date has recruited 24 patients in a 2-to-1 randomization of avelumab plus TKI versus TKI alone. And it's also doing a number of additional laboratory studies to better understand T-cell function and phenotype. And the study continues to recruit. So in conclusion, the immune system is deregulated at diagnosis of CML. TKIs correct some of this deregulation, but also have effects of their own. The landscape contributing to successful TFR, as you've seen, is very complex, and it's likely that both leukemic stem cells and the immune system play important roles. Already, roles are suggested for NK cells and plasmacytoid dendritic cells in treatment-free remission, and studies are underway to better understand the biology of TFR and possible strategies to increase the number of patients able to attempt and maintain TFR. And these include trials of interferon alpha, immune checkpoint inhibitors such as avelumab, and also non-immune interventions to specifically target the CML stem cell. Finally, ahead of the presentation, I was given a few pre-submitted questions, so I'm going to just quickly run through those now. So the first question was, am I more inclined to use interferon alpha plus tyrosine kinase inhibitors for patients wanting to attempt TFR? So my answer to this is no, because within the UK, interferon alpha is not approved for use in patients with chronic myeloid leukemia. So for those patients attempting TFR in my practice, they wouldn't receive interferon alpha either into the run-up or of a TFR attempt or as maintenance after stopping TKI. The second question was, is there any relationship between TKI dose intensity and enhancing immunomodulation that optimizes a patient's TFR success rate? The answer is we don't know at the moment, but we have just received funding from Cancer Research UK to investigate this very question in patients who were enrolled in the Destiny clinical trial, which has subsequently reported. And we're very excited to be getting started on this work, so watch this space. And the third question was, in order to move beyond the current plateau of TFR success of around 40 to 50%, where I hypothesise that immunomodulation and TKIs are the most likely therapeutic strategy. I think this is a really difficult question and it is a bit of an unknown, but I think there is quite a good chance that the immune system and correcting abnormalities in the immune system caused by CML is going to be a really effective strategy for increasing the number of patients able to attempt TFR. However, I'm not convinced it's going to be for every patient, and I think we may need to develop a range of different approaches. We may need to accept, unfortunately, that for some patients, that lifelong TKI treatment may be required, and we may need to think about CML in those patients, like we do for other chronic medical disorders, such as an underactive thyroid or high blood pressure, where patients need to be on lifelong treatment. And thank you very much.